Hey guys, welcome back to my channel, or welcome if you're new here. I'm sorry that there's been a bit of a delay in getting videos out to you guys. I have been going through a little bit of home construction and it has definitely diminished my ability to be able to put videos out as quickly as I would like. However, we are back today with a quick pathophysiology video, and today we're going to be talking about tuberculosis. So as we start talking about tuberculosis, this is a highly infectious, and that is very important, process, and it's caused by Mycobacterium tuberculosis. That's the name of the bacteria. It does spread through aerosolization, so it is airborne precautions. And of course, that means that when the client coughs, laughs, sneezes, they are spraying those fine particles out into the air. So again, airborne transmission. Now, the risk of transmission does decrease after about 2 to 3 weeks on anti-tuberculin therapy. Now, tuberculosis does primarily affect the lungs, but it can spread to any other body organ, and that's called miliary TB. Now, we're not going to talk much about that today. We're mostly going to focus on respiratory TB, but just know that it can spread to other body organs. Now, once inside the lungs, the body is going to encase this bacteria with collagen and other cells, and it actually looks like a nodule on chest x-ray. And you can see, hopefully, in this chest x-ray, some of these little nodules that these arrows are pointing at. And those are called tubercles. Early detection is essential for tuberculosis. Now, only a small percentage of people who are infected with tuberculosis will develop an active form of TB. Other people will develop what is called latent TB, in which the bacteria will lie dormant in the body, and this can happen, it could be dormant, gosh, for years before then it actually becomes activated into an active form of tuberculosis. So latent TB, of course, that is people who have been exposed but have not developed the disease. So the bacteria is in the body, but the body has so far been able to fight off the infection. And as we've mentioned, it can lie dormant for many, many years, and then it typically becomes active as the client ages or once they become immunocompromised. Now, we do often, though, give people with latent TB anti-tuberculin medications as a prophylaxis to prevent that infection from becoming active. Now, so initially, this bacteria is going to enter into the upper lobes of the lung first, or affect the upper lobes of the lung first. You'll get enlarged lymph nodes, and then you'll have a period of really asymptomatic clients, right? They have very, very few symptoms and really no traditional symptoms of an active TB infection. Now, again, that's latent TB, and that stage can continue on for, gosh, years, weeks, months, years, until that tuberculosis infection does become active. Now, your client, this is important to remember, is not contagious until those traditional symptoms start to develop. Now, a secondary infection, that's where that tuberculosis has been latent and now it is reactivated from a previously infected person. So the bacteria has entered the body, but it's laid dormant for a period of time, and now you're getting an activation of that bacteria where the client once had latent tuberculosis. Now, again, just as we mentioned, this is more common in older clients or in immunocompromised clients. So let's talk about those traditional symptoms of tuberculosis. So that persistent cough, and this is a cough that lasts longer than 3 weeks. It's just this persistent cough. There's sputum. The sputum is purulent, so it has an odor. It's often discolored, and it might even be blood tinged, so hemoptysis. The client has extreme fatigue and lethargy, and in fact, they're losing weight. They're not hungry. Night sweats. That's a really common symptom that clients report with tuberculosis. Also a low-grade fever. And then as respiratory function, gas exchange does start to decline, altered mentation or altered mental status, and unusual behaviors. Some clients, again, because of this persistent coughing, will report a chest tightness or just this dull, achy chest pain, especially when they cough. And then if you, as the nurse, go in to percuss those lung fields, you'll hear dullness over the lung fields that are involved. And then you might even hear crackles and wheezing from bronchoconstriction. Now, just as we mentioned previously, let's touch just quickly on miliary TB. So this is TB where the bacteria is not just in the lungs, but it has now invaded the bloodstream and it has spread to our other body organs. So we might see things like headaches, neck stiffness, and drowsiness. Now, these symptoms, this miliary TB, this can be life-threatening. Pericarditis is also pretty common with miliary TB. We'll get distended neck veins, dyspnea, pleuritic pain, hypotension. The good news is the way that we treat it is the same as we treat pulmonary TB. So whether you have miliary TB or pulmonary TB, we're going to be using the same medications to treat tuberculosis. So hopefully this quick pathophysiology discussion about tuberculosis was helpful for you. If you would like to know more about how we treat tuberculosis, in particular, the very specific medications that we use, check out my Etsy shop. I do have a study guide on the medications used to treat tuberculosis. Otherwise, have a wonderful day. I will see you in the next quick pathophysiology series. You can certainly reach out to me via email or my Twitter account, or I can also be found on Instagram at @theprofessorRN as well. Have a wonderful day, and I will see you next time. Bye.